They account for only 3% of head and neck malignancy. Overall, the experience of general pathologists is very limited, and it is never a popular CME topic. I'm not going in details of it. You will understand if I say it is not a popular. The terminologies are quite confusing, and as I mentioned, newly described rare entities come up every 2 years. There is a histological diversity within one group, and there is a morphologic overlap between two different groups. And that results in a wide differential diagnosis for each case. The biopsies are always small. The tumors can be poorly differentiated. You may get necrotic or hemorrhagic portion, which is a dependent portion. And therefore, there is a diagnostically challenging cases. Moreover, the histopathology is the gold standard in sinonasal tract. Therefore, onus of diagnosis essentially rests on the pathologist. I must tell you here that imaging, say CT, MRI, are so much useful in the other regions of the body, but they are not that useful in the sinonasal tract. They tell you what is the epicenter and what is the extent of the lesion. Besides that, they are not of much help. So also there are not many tumor markers in sinonasal tract. So let's see how morphology offers the diagnosis. So the diversity of the tumors relates to a histogenesis, the morphology spectrum within each group, and the overlapping morphology as I just mentioned. So we have epithelial tumors, spindle cell, round cell, like any other site, lymphoid tumors, there are primary lymphomas of sinonasal tract, and undifferentiated tumors, which forms a large group. Though uncommon, there are very many undifferentiated tumors in sinonasal tract, unlike other systems. Now this one looks a bit complicated, but the idea is to tell you that you take a group of round cell tumor, some of them will be spindle cell, and as you see in spindle ERMS, whereas synovial sarcoma, which is usually spindle cell, synovial sarcoma, which is usually spindle cell, can look round cell when it is poorly differentiated, or also epithelial cell. So also the epithelial tumors can look spindle cell when they are called sarcomatoid carcinoma or spindle cell melanoma. And that is one of the reasons for difficulty in diagnosis. So this is overlapping morphology seen between two different groups. So this is the latest WHO classification, 5th edition 2022. And here we give you epithelial malignancy breakup. Then there are benign tumors and non-epithelial tumors. So when we look at epithelial malignancy, of course, the common may be squamous carcinoma as usual, which can be keratinizing, non-keratinizing, very rarely basaloid type of squamous carcinoma. But a new entity has been included in this particular group, that is DEC-AFF2 fusion carcinoma of the sinonasal region, which looks like non-keratinizing, but when you do this fusion, you come to know that this is a different tumor. Nut carcinoma, all of us know by now, which is a midline carcinoma seen in the younger individual. Then you also have SWI-SNF complex deficient carcinoma, which is also a new entity. Sinonasal lymphoepithelial carcinoma can be primary in the sinonasal tract, like nasopharynx, which is different from sinonasal undifferentiated carcinoma. We have IDH mutated carcinoma, which is a new entity. Teratocarcinosarcoma, an old entity. HPV associated multiphenotypic sinonasal carcinoma, a new entity. And now the adenocarcinomas have been separated and they are divided into intestinal type and non-intestinal type. We will come to it little later. Now, benign tumors are specific for sinonasal, and here we include sinonasal papilloma, most common benign tumor, and juvenile angiofibroma, also common tumor seen in the male adolescents. We have chordoma, schwannoma, pleomorphic adenoma, osteoma, giant cell tumor like a bone tumor, and meningioma, glioma. In fact, we can also get pituitary adenoma, ectopic pituitary adenoma in the sphenoidal sinus. Amongst non-epithelial tumors, these are the common tumors which you see in any other organ also. So if we concentrate on the epithelial malignancy, we have squamous carcinoma, adeno, which is divided into intestinal, non-intestinal, further divided into sinonasal adenocarcinoma and salivary type of adenocarcinoma, which are more common. And then we get a big group of non-squamous non-adenocarcinoma. In this, we have to first separate sinonasal neuroendocrine carcinoma, which are usually poorly differentiated. You hardly ever get carcinoid tumor in the sinonasal tract. Then HPV-associated multiphenotypic carcinoma, SNUC, undifferentiated carcinoma, lymphoepithelial, all those new entities which are enumerated in the previous classification, sinonasal teratocarcinoma sarcoma, and many more are emerging. So what is the classification of adenocarcinoma? Intestinal, non-intestinal, low-grade seromucous, low-grade sinonasal, tubulopapillary, and RCC-like adenocarcinoma. These are all primary adenocarcinomas of sinonasal tract, and all of them are quite rare. But we have to know them to be able to distinguish one from the other. Salivary type, we are all aware, these are the salivary gland tumors, and all of these can be seen primarily in the sinonasal tract. Besides, we can also have oral salivary gland tumors which can extend to maxilla and nasal. When we are discussing the primary adenocarcinoma, we should not forget metastatic carcinoma from the common primaries, that is kidney, breast, lung, and GI tract. And sometimes we really have to distinguish these two to be able to say that this is really primary adenocarcinoma of sinonasal tract. Now, as a representative, I have taken adenoid cystic carcinoma, which is the most common salivary gland tumor or most common adenocarcinoma seen in the sinonasal region. Here, grading is very important, graded as 1, 2, 3. Grade 2 is commonly seen. Now, differential diagnosis of this tumor will depend on what is the grade. If the adenoid cystic carcinoma is of grade 1, you will have to distinguish it from pleomorphic adenoma, polymorphous adenocarcinoma, epithelial myoepithelial carcinoma. If it is grade 2, it has to be distinguished from myoepithelial carcinoma, because then you may not see tubules in the tumor. Whereas if it is grade 3, you have to distinguish from basaloid squamous cell carcinoma and basaloid adenocarcinoma. PNI are seen quite often in adenoid cystic, and one has to look for it. It can be either anterograde or retrograde. In spite of adequate treatment, this tumor has tendency to recur, and that depends on the surgical clearance. And this is the site where the surgical clearance is very difficult, and therefore recurrences are common. However, lymph node metastasis at presentation are quite rare. So usually you get the history of number of times recurrent adenoid cystic carcinoma. When you do see lymph node metastasis, you have to think twice whether it is really adenoid cystic carcinoma, unless it is of grade 3 malignancy. Sometimes, or very rarely, you will get high-grade transformation in adenoid cystic carcinoma, then you can get lymph node metastasis. But there, the history will be of long standing. It is sort of a de-differentiation in the existing tumor. What are the immunohistochemistry? CK7, CEA, and c-KIT, which will highlight the luminal cells, P63, calgonine, and SMA, which will highlight the myoepithelial cell. And you also have genetic abnormality, as you see in NF5B gene fusion. Many of the salivary gland tumors have genetic abnormality, but I don't think we have to really use it for diagnostic purpose. There may be isolated incidences where it can be used, or the tumor can be tested for diagnosis. We all know how adenoid cystic carcinoma looks. This is grade 1, wherein we are supposed to see bilayered tubules, inner ductal or tubular, outer myoepithelial. Whereas these are pseudo tubules or adenoid spaces where we don't have actually the ductal epithelium. This is myoepithelial cells, and you get myxoid material. This is grade 2, which show nest with the cribriform spaces, which are very punched out. Occasionally, you may see bilayered tubules, and that helps you, in fact, to diagnose that this is adenoid cystic carcinoma. This is one such area where you get inner ductal and the outer myoepithelial, where you get secretions within. Then you come to see grade 3, where you get nest, and sometimes you can see comedoneal necrosis, and this can also show bone infiltration. And this is very high grade, and you have to really distinguish it from other high grade tumors. Now, perineural invasion one has to look for in adenoid cystic carcinoma. Sometimes it may be difficult because of crushing artifact, but you have to pay attention to the perineural invasion. The other common tumor is the intestinal type of adenocarcinoma, which usually seen in ethmoid sinus and nasal cavity. This is associated with exposure to hardwood, dust, or nickel, and therefore it was popularly known before as woodcutter's disease. It arises from intestinal metaplasia of the lining epithelium, that is respiratory epithelium. And like colonic carcinoma, it shows CK20, CDX2, Villine positivity, so also MUC2 and CA positivity. But because it originates from in the sinonasal tract from the lining epithelium, it also shows CK7 positivity. However, this being a rare tumor, it is better to rule out the metastasis from colon before calling it intestinal adenocarcinoma. Because morphology, immunohistochemistry, except CK7 and RAS mutations are common to both these tumors, that is primary and metastasis. This tumor is also graded as grade 1 to 3. Grade 1 will be very differentiated, where you will see glands or papillae. This is grade 2, where you see irregular glands and classical stratified epithelium with thin pencil nuclei. And this is grade 3, where you see garland type of necrosis as is shown here, and also the goblet cell, which help you to suggest that this is colonic type of carcinoma, which is called intestinal type of carcinoma. So on immuno, it will show CK7 positive, CK20 positive, CDX2. Sometimes few cells will be lit up with the chromogranin because some kind of neuroendocrine cells also you may get there. Now we go to the next adenocarcinoma tumor, which is very low grade, as you can see over here. It basically shows the glandular pattern. Here it is showing papillary projections, hardly any stroma in between, and the cytoplasm is clear, which is very prominent feature over here. The nuclei are low grade. Does it look like a renal cell carcinoma? So we do immunohistochemistry where CK7 and EMA are positive. CN9 also can be positive, which is usually weak. This was the only area which was positive in this particular tumor, and SOX10 was positive. So initially we were thinking whether it is metastatic renal cell carcinoma. But when we did PAC-SET, the PAC-SET came negative, and therefore we dropped that idea and we concentrated on the morphology, which was very low grade. So this is rare primary adenocarcinoma of the sinonasal tract where PAC-SET is negative, that is necessary for diagnosis. And RCC, because we know that RCC can really remain silent and may not be detected on PET scan. Therefore, the nasal metastasis can be the first presentation of the renal cell carcinoma, and I have seen 4 cases like that while working at Tata Hospital. The Ki67 index is also low because it is usually low-grade carcinoma, unlike RCC, and you have to distinguish from metastatic RCC for the obvious reason that prognosis will be much better here. Look at this tumor and compare it with the previous tumor. This is also showing clear cytoplasm, but there are hardly any tubules, and the nuclei look pleomorphic. There are nucleoli also, and you can see pleomorphism very easily. So here also we carry out the immunohistochemistry, CK-EMA, and this is naturally PAX8, and which is positive. So this is like a true renal cell carcinoma, which was metastatic to the sinonasal tract. And after suggesting the renal mass was detected on USG, this was like a hidden primary, and then it could have been treated differently as compared to the primary sinonasal adenocarcinoma. So from the differentiated group of adenocarcinoma, now we move on to undifferentiated group. This was 55-year-old female who presented with nasal swelling and maybe blockade. Now I would like to highlight here one thing, that all nasal tumors, the big range, they have similar symptoms. Nasal swelling, blockade, obstruction, that is one, and epistaxis. So from the symptoms also, you cannot really distinguish. Maybe from the period, if the long-standing tumor is there, it may be more benign or low grade. That's the only way you can suggest, and rapidly growing may be high grade. So this was one such tumor wherein we basically saw the nest of basaloid looking blue cells with abundant stroma. We tried to look for any differentiation, but no glandular or squamous differentiation was seen. It was obviously high grade with very many necrotic areas within. The nests were irregular and there was no palisading, and it was compactly arranged cells were there which were rather monotonous. That is, for the high grade tumor, we did not see much pleomorphism within the nest and there was no differentiation either. So it was basically undifferentiated tumor, and obviously it looks carcinoma because it is forming nest and very cohesive. So the differential diagnosis included basaloid squamous carcinoma, which shows focal abrupt squamous differentiation, which wasn't seen. HPV-associated carcinoma, which can show basaloid cell, but it is usually multiphenotypic. So you also see acinar cell, you may see cribriforming. High-grade adenoid cystic carcinoma, which focally shows tubular or cribriforming. And I have also mentioned the immunohistochemistry. Look, P63 and epithelial markers are commonly positive in all these tumors. Then comes SMARCB1 deficient basaloid carcinoma, which will also be P63 positive, but SMARCB1 will be lost. And you have SNEC also, that is sinonasal neuroendocrine carcinoma, where also P63 can be focally positive, but their neuroendocrine markers will be positive. Now, in situ carcinoma is seen in HPV-associated and basaloid squamous carcinoma. All the other tumors will not show in situ carcinoma. So, immunohistochemistry in this tumor was CK, EMA and P63 positive. But does this give you any idea what sort of a tumor it is? No, you have to go further and get further immunohistochemistry done. Of course, we did neuroendocrine, we did for adenoid cystic carcinoma, but we also did one marker which was lost. Can you imagine what is this marker? So this is actually INI1, which was deficient in this case. Entire tumor was devoid of INI1. This is positive only in the endothelial cells. In contrast, this was the case of a basaloid squamous carcinoma, which also showed nest and the basaloid cells, wherein the INI is nicely retained. So with this, you can diagnose it as SMARCB1 deficient carcinoma of sinonasal tract. Now, in contrast, this is another tumor which is large and it looks very pink. That also presented with nasal obstruction and bleed. Here the cells are large and epithelioid, loosely cohesive in comparison to the previous one, which was compactly arranged nest, round nuclei, prominent nuclei, and abundant eosinophilic cytoplasm. Okay, these are three different sections showing different, and it was mitotically quite active. Again, we carried out CK, EMA, and P63, and after adding some more immuno, we added INI1 also, and here also that INI1 is negative, and this is also form of a SMARCB1 deficient carcinoma of sinonasal tract, because this tumor has different morphologic type. The first one I showed basaloid type of carcinoma without any differentiation. The second one is epithelioid carcinoma. You can get plasmacytoid cells or rhabdoid cells also. And the third category of SMARCB1 deficient carcinoma is adenocarcinoma, wherein you see unequivocal glands as well as yolk sac-like pattern. And this is the article where Agaime Abbas has described a series of 39 cases of SMARCB1 or INI1 deficient sinonasal carcinoma. Incidentally, we had opportunity to listen to Abbas Agaime at the month in just last month. So this is one such example of SMARCB1 deficient where large epithelioid cells are seen, and what you can observe closely is there is some kind of a paranuclear clearing. Many cells are showing this paranuclear clearing, okay, and the nuclei are showing prominent nucleoli. Otherwise, there is no glandular differentiation. So these are actually a rhabdoid cells, and this is what I meant by paranuclear clearing or HOF. Like you see in plasma cell, and if you do electron microscopy, that is represented by a tangle of intermediate filaments. This is called filamentous cytoplasmic inclusion, which is seen in the rhabdoid cells. So this rhabdoid morphology is also seen in SMARCB1 deficient sinonasal carcinoma. So what is the differential diagnosis for this form? Amelanotic melanoma, large cell neuroendocrine carcinoma, and myoepithelial carcinoma. Both these will show prominent nucleoli, both can show necrosis. Myoepithelial carcinoma usually doesn't show prominent nucleoli, but they can show plasmacytoid cells. Diffuse pattern, loosely cohesive cell, dense pink cytoplasm. But they all can be distinguished with the help of immunohistochemistry. So while seeing the morphology and making morphological analysis, you have to generate a differential diagnosis, then only you can order the immunohistochemistry. So for this kind of a morphology, you may have to order some neuroendocrine markers, that is synaptophysin and CD56. Chromogranin is also added, but usually in a poorly differentiated neuroendocrine carcinoma, chromogranin may be focal and therefore CD56 is added. P40 or P63 is usually put in all undifferentiated tumors in sinonasal tract. I would like to mention here that unlike oral cavity where P63, P40 positivity will mean either squamous carcinoma or rarely it would also indicate myoepithelial carcinoma. In sinonasal tract, I had just shown that many undifferentiated tumors will show P63 or P40 positivity. So large cell neuroendocrine carcinoma, neuroendocrine markers will be positive, whereas other markers will be negative. All these are very rare tumors, but you never know which rare tumor will be on your tray, sitting on your tray, and therefore you have to be aware of all of them. We go to the next interesting tumor, maxillary swelling. This was contributed to me by Dr. Garcia. Look how nice it looks. Nest. Elongated nests are seen with a lovely palisading all around, and tumor is showing spaces within. It does have adenoid cystic-like pattern, but the question is it really adenoid cystic carcinoma? Will you call it cribriforming? It is not really true cribriforming. Okay, and palisading is seen over here also. You will get stroma, which can be desmoplastic, can be hyaline also. You will get solid areas, and you can get tubular areas also, cribriforming also. Now in this case, the overlying epithelium showed in situ carcinoma, and which was a big lead for the differential diagnosis. So CK was positive, wanted to rule out adenoid cystic carcinoma, CD117 was positive, P40 was positive. So what I'm trying to tell you, P40 is not really an important marker, an important distinguishing marker in sinonasal tract, but P16 was also positive. So the question is it adenoid cystic carcinoma? Here it is good looking like a cribriforming, and you feel there are bilate tubules. This is P63. So inner ductal and outer myoepithelial sort of a thing. So one may think that it's adenoid cystic, but it is not, because the nests are showing palisading, and adenoid cystic doesn't show palisading. It is the basaloid squamous and basaloid adenocarcinoma which can show palisading around the nest. There is no true cribriforming. There is no myxohyaline or hyaline cylinder that you see in adenoid cystic. Besides, you don't see in situ carcinoma in adenoid cystic carcinoma. And there is a lack of repetitive pattern because basically this is multiphenotypic tumor. So we now come to with HPV DNA-ish positive, it is HPV related multiphenotypic sinonasal carcinoma. All these carcinomas may not be really multiphenotypic, that means may not show different areas in every section, but you can get variety of patterns and you have to look for them so that you can easily suggest the possibility of HPV, and then you have to get P16 and if required even HPV-ish for the confirmation. So here we have virus-associated sinonasal tumors. The important ones are nasopharyngeal carcinoma, also extranodal NKT cell lymphoma, which is in fact a primary lymphoma of sinonasal tract, and which shows angiocentricity, angio invasion, wherein the EBV association is almost 100%. When we talk about human papillomavirus, it is basically HPV-related carcinoma with adenoid cystic-like features, which we just saw, wherein you have to demonstrate HPV positivity because it is deficient. In addition to this, we have Schneiderian papilloma complicated by squamous cell carcinoma, where you can get high-risk HPV positive. In contrast, Schneiderian papilloma without dysplasia or carcinoma will be associated with low-risk HPV only in 20 to 25% of cases. And this is a nice article by Justin Bishop, where he discussed human papillomavirus-related carcinoma with adenoid cystic features, a peculiar variant of head neck carcinoma, which is so-called restricted to the sinonasal tract. Another undifferentiated tumor composed of loosely cohesive irregular nests without any differentiation. But here, look, the nuclei are very pleomorphic. It is a large nuclei, they are very pleomorphic, loosely cohesive cells, lot of apoptosis. You get comedonecrosis as well. You can see, as you see here, comedonecrosis, vascular invasion, and in this tumor also you can see in situ carcinoma. It's not easy to get in situ carcinoma in a biopsy, but one has to look for it the way we look for in the squamous carcinoma. So this is true sinonasal undifferentiated carcinoma, and here also sinonasal tract epithelial tumors will be CK7 positive, whereas chromogranin, synaptophysin and P63 is negative. So all these markers will be negative in SNUC. NAC can be seen focally, but these days nobody uses NAC, and HPV and EBV are negative. So by ruling out all these markers, you can diagnose SNUC, where P63 is negative, unlike other tumors where P63 will be positive. So this is the spectrum of polydifferentiated / undifferentiated carcinoma. You have to think of non-keratinizing squamous and this new entity. Then you also get polydifferentiated sebaceous carcinoma in the sinonasal tract from the ocular site, from the nasolacrimal duct, and you get a pagetoid spread. We have seen cases like that which sometimes are mistaken for squamous carcinoma. You have neuroendocrine tumors like sinonasal neuroendocrine, which is polydifferentiated, large cell neuroendocrine, I showed you the example, and very rarely small cell carcinoma can be seen. You have SNEC and IDH mutant carcinoma, where P63 will be negative. You have nasopharyngeal undifferentiated carcinoma can extend to sinonasal tract, or you will have a lymphoepithelial carcinoma which will look similar to it, but which can originate primarily in the sinonasal. SNTCS, which is very interesting and a rare primary sinonasal tumor, nut midline carcinoma, SMARCB1 deficient and SMARCA4 deficient carcinoma. So you see the spectrum is very big and unique. Previous pathologists were lumpers because, not by choice, but they didn't have the scientific advances of genetic abnormalities. And today's pathologists are splitters, and that's why our classification is ever increasing. Now, it is not possible to cover all this, but I have given you idea how to go about them, how to make a differential and try to rule out the ones which have a specific markers, like HPV, EBV can be always tested in those tumors. Now you see yet another undifferentiated tumor which is seen in the midline and usually in the young patients. It is very aggressive, and this also can show you different areas. But the common appearance will be like an undifferentiated round cell tumor. It's not very cohesive. You can see spindle cells in this. You can see focally clear cells and little larger cells, and there can be abrupt squamous differentiation also. Now, abrupt squamous differentiation is seen mainly in this tumor and also in the basaloid squamous carcinoma. So, spindle cell morphology, extensive neutrophilic infiltration and rosetting were observed in our study, but this is not common appearance. Common appearance, I told you, is the undifferentiated round cell tumor. The mitotic activity is there with areas of necrosis because this is very aggressive tumor, and this is breakup of our immunohistochemistry. Majority of them showed AE1, AE3 positivity, P63 positivity, also P40 where it was done. In addition to, I already spelled out NUT antigen. Sometimes you see high-grade morphology and larger cells in this particular tumor. And here also you are seeing the squamous, so-called squamous differentiation. Squamous differentiation will be with keratinization, without keratinization also. So you see CK, again P63 positivity, but all the other markers for round cell tumors will be negative. Here we have shown LCA and MIG2, which are negative. The most important marker will be, of course, NUT antigen, which was classical that speckled or punctate positivity, intranuclear positivity, and this can be confirmed with the FISH test, where you can see the break apart probe will show you separation of the green and the red signal, as you can see here, and here you can see the separation. So this can be diagnosed with the FISH technique. So there are various tables in the literature, including different kinds of undifferentiated tumors. So x-axis will be different, y-axis will be different, there will be different markers used, but you have to use the combination of immunohistochemistry markers, viral markers, and also genetic alteration wherever it is available, like NUT midline, you have solid adenoid cystic carcinoma and SMARCB1 deficient carcinoma. So various tables are there, and when in trouble, you can always refer to these tables. So with this, we go to the round cell tumors. This is also a very big group. And here I have listed the usual round cell tumor, which all of us are used to diagnose in the different areas, whereas the unusual round cell tumors which are seen in the sinonasal tracts are other than the pediatric round cell tumors, like small cell melanoma, primitive neuroectodermal component of sinonasal teratocarcinosarcoma will mimic a round cell tumor. NUT midline carcinoma we just saw. SNUC, SNEC are also small cell type, undifferentiated type. So also basaloid tumors, and of course poorly differentiated synovial sarcoma. So these all will appear round cell and may come in the differential diagnosis of round cell tumors, in addition to some of the lymphomas which are small to intermediate type. So this is one such round cell tumor which is showing some pattern. This was the case of a 15-year-old female who presented with parotid mass and came with the diagnosis of poorly differentiated adenocarcinoma, maybe because it was a parotid mass and it showed some kind of a alveolar pattern, as you can see. But the actual cells are small, round. They do not look epithelial, and there are no true tubules. There was no stroma. So in addition to the small round cell, there was this I have shown on the high magnification. There were giant cells and the large cells as well. This one looks almost like a tadpole type of cells with multinucleated giant cells. There was mitotic activity also, and then this was diagnosed as a round cell tumor, and the review of the old slides showed, as I mentioned, the giant cell which appeared wreath-like. Okay. So I am giving you the diagnostic clues. So this was actually alveolar rhabdomyosarcoma. Now you will ask me how it came into the parotid. So it was metastatic to pre-parotid node. Node was completely replaced by this particular tumor. We did not get primary then, and in the next year, in fact, patient came with the nasal obstruction and he had the primary there, which was biopsy, and with lymph node metastasis which presented earlier in pre-parotid node masquerading as the primary. So think about rhabdomyosarcoma first in head and neck region. When you see round cell tumor with or without alveolar pattern, because you can have solid variant of alveolar rhabdomyosarcoma, especially in children and young adults, but it can be seen almost up to age of 40 years. And always order desmin in every poorly differentiated tumor in head and neck, particularly in children and young adults, irrespective of the morphological appearance. Then only you can pick up all these rhabdomyosarcoma. and do not push the tumor in a fixed slot even if it shows synapto CD56 CK or MIC2, and I will explain to you a bit later. So this was another tumor in 39-year-old male who presented with neck mass. The previous was parotid mass, which was metastasis of alveolar rhabdomyosarcoma. I think I missed, there was of course desmine, myogenin, immunohistochemistry was there. I missed that slide. And this is another case, there was no primary detected, and looking at this morphology, we started suspecting neuroendocrine carcinoma. So why I am showing you this case, this is not a usual occurrence, but your immunohistochemistry are the ordered based on your morphologic diagnosis. Since we thought it could be neuroendocrine carcinoma, we ordered synapto, chromo, and CK. And see, CK is nicely positive, synapto is positive, but the chromogranin was negative, totally negative. And we asked to see the sinonasal tract because that is the common site for the neuroendocrine carcinoma, which is poorly differentiated, as you can see there, and that tract was normal. So naturally, we had to rethink about our diagnosis. Then we realized it is one of the round cell tumors. So we quickly ordered desmine, which was positive. Then of course, myogenin, which came nicely positive. So we could label it as alveolar rhabdomyosarcoma. So that is why I meant that even if your CK, synapto or MIC2 is focally positive, always keep in mind that alveolar rhabdomyosarcoma, a solid variant, can show this positivity, and do not forget to ask for desmine and myogenin, particularly in head and neck and sinonasal tract. So this is a summary of diagnostic features of sinonasal so-called round cell sarcoma. You get rhabdomyosarcoma, Ewing sarcoma, desmoplastic small round synovial, and the peculiar tumor is mesenchymal chondrosarcoma, which is seen in the sinonasal, which shows two components, again undifferentiated round cell and cartilaginous component, and small cell osteosarcoma. Mind you, these are all rare tumors except rhabdomyosarcoma, which can be embryonal or alveolar. These are all rare tumors, but they do come in differential diagnosis. So therefore, you must know what immunohistochemical markers to order. They all have sensitive and specific markers. What I have given in the red are the specific. Desmine positivity doesn't mean it is rhabdomyosarcoma. You have to confirm with myogenin and myoT1. So also Ewing sarcoma, CD99 will be seen in variety of round cell and other tumors. So all these are the specific markers. So your idea is first order sensitive markers and then go to the specific markers. And even genetic fusions and abnormal rearrangement is useful for a diagnosis in difficult cases. Unlike in carcinoma, in sarcomas or in pediatric round cell tumors, we tend to order these particular tests for confirmation, which is very necessary because your chemotherapy will depend on the specific lineage. So MIC2 is one marker which is not at all specific. It is seen in ESP-NET, membranous positivity, but it can also be seen in T lymphoblastic lymphoma, where LCA can be negative, and the diagnosis, we have seen cases of T lymphoblastic lymphoma in sinonasal tract and also in the bones, which came with LCA negativity and MIC2 positivity, based on which the primary diagnosis suggested was PNET, only to know later on that on addition of TDT, which came positive. So these were the cases of T lymphoblastic lymphoma. Alveolar rhabdomyosarcoma, we saw that can show MIC2 positivity. So also small cell synovial sarcoma. Mesenchymal chondrosarcoma shows MIC2 positivity, but SOX9 is the specific marker. SNTCS, that is teratocarcinoma sarcoma, can also show MIC2, but there you have to look for other elements and you will hit the diagnosis. So the moral of the story is, do not rely on MIC2 alone. Previously, we didn't have so many markers, so we had to rely on the MIC2. The scenario has changed now. So this is what I was talking about, the diagnostic approach. Clinical diagnosis may not help you much. They may say malignant tumor or in maybe possibility of round cell tumor. We have to do morphological analysis and do morphological differential diagnosis, generate differential diagnosis. Then you order the primary immunohistochemical panel, which should include the sensitive markers for your differential diagnosis. Based on the positivity of your immunomarker, you will then have a secondary immunohistochemistry panel, which will include specific markers, and then your diagnosis can be clinched. Sometimes you may have to order tertiary panel when there are morphologies overlapping, or even immunohistochemistry markers can be overlapping, as we just saw in the MIG2. So how do we do it? Ordering immunohistochemistry marker panel. So you must include CK-EMA in sinonasal tract. At other sites, we may not include this. Desmin must, MIG2, synapto, LCA, and then depending on your choice and depending on your differential diagnosis, you will have the primary panel. And this will be secondary panel that should be more specific. If you get CK-EMA positive, you will order P63, INI1, NUT, particularly in the younger patient, in the midline tumor. Desmin, I mentioned myogenin, myod1, MIG2, Fly1, NKX2.2, also LCA and TDT, synaptophycin, chromogranin, which will be more specific. CD56 is important in polydifferentiated neuroendocrine carcinoma. For LCA, other markers, and of course, S100 doesn't diagnose melanoma, particularly not amelanotic melanoma. You have to prove it with HMB45, Melan-A, or SOX10. So sometimes even a tertiary panel may be necessary. With this, now we go to the spindle cell tumors of the sinonasal tract. Look at the magnitude. I have some time, right? So just to enlist this tumor, the sarcomatoid carcinoma, spindle cell melanoma, you have to first rule out these tumors in sinonasal tract before you come to non-epithelial spindle cell tumors. Here you will get variety of the tumors. These are the common tumors you can see in other sites. You also get spindle cell osteogenic sarcoma, MPNST, rhabdomyosarcoma. You get primary leiomyosarcoma in sinonasal tract. And these are some other tumors, and you have this specific tumor that is biphenotypic sinonasal sarcoma. So this was one such polypoid tumor in the nasal cavity, as you can see here, which was composed of spindle cell only, and there was no differentiation seen. It also extended to maxilla. Okay, can you make out what it is? Here the nuclei look little hyperchromatic, but here the nuclei show some nucleoli. Okay, the inclusions were not seen. Maybe here there was something like an intranuclear cytoplasmic inclusion. So any guess? Is it sarcomatoid carcinoma? We did not see any squamous differentiation. There is no in situ carcinoma in the overlying epithelium, because that also can be polypoidal. Spindle cell melanoma, well, the pigment was not obvious, but this is, I have taken high power only to show you that somewhere maybe you feel that there is a little pigment over here, but one cannot be really very sure. You cannot see the pigment granules as such, so you have to depend on immunohistochemistry. So here we ordered, of course, CK, P63, which were negative, S100, HMB45, both have come positive. This is amelanotic melanoma. Throughout it was amelanotic. Sometimes some sections can be amelanotic, but some other section can show you the nice pigment in the cytoplasm, which makes your life easy for the diagnosis. So this was our study of primary mucosal melanoma of sinonasal tract, wherein 30% were non-pigmented, and that's why you have to keep as in a differential diagnosis. Usually polypoidal can arise from the nasal septum. The nuclei can be hyperchromatic, unlike the popular thinking that the melanoma has vesicular nuclei and very prominent nucleoli. Melanoma is the greatest masquerader. It can masquerade epithelial tumors, round cell tumors, because you have round cell variant, and also spindle cell tumor. You can look overlying mucosa for in situ chain, and sometimes you see nice nesting pattern towards mucosa, which is lost lower down. So what panel you ask? S100, HMB45, Melan-A, and SOX10. These can show diffuse and strong positivity is very diagnostic. It usually lacks the epithelial markers. But in case any spindle cell tumor shows S100 focal positivity and HM45 negativity, then please think twice before calling it melanoma, because there are so many other tumors which can show you S100 positivity. So So this is one such newly described sinonasal sarcomas, which is primary in the sinonasal tract, which can show you fasciculation, and it can also show you some hemangiopericytomatous like pattern. But note, there is not abundant ropey collagen as you would see in the solitary fibrous tumor. It looks little more cellular, but it is not very high grade. Sometimes you can see biphenotypic appearance because of epithelial proliferation within this tumor. Epithelium is bland. It can be either glands or it can show oncocytic appearance, as you can see over here. And what immuno you will order? Of course, you have to include S100 and SMA as a common immunomarkers. You will also include P63, calponine, CD10, because one has to rule out spindle cell myoepithelial carcinoma, which we have seen in the sinonasal tract. So this was the example of a fine biphenotypic sinonasal sarcoma. You have to distinguish basically from spindle myoepithelial carcinoma, leiomyosarcoma, and then of course sarcomatoid carcinoma, which will be more aggressive, which will show you pleomorphism and necrosis, mitosis, whereas this tumor is low grade and therefore even the Ki67 will be very low. So you do use ancillary techniques. In addition to IHC, even the molecular markers are important, mainly as I mentioned in pediatric round cell tumor and the sarcoma. So even biphenotypic sinonasal sarcoma has specific genetic abnormalities as shown here. ARMS we all know, synovial sarcoma, these are the standard molecular abnormalities, and Ewing sarcoma also. So we do use this for diagnostic purpose, unlike the carcinoma where we hardly use the markers for diagnosis. Now I have to show you this slide that diagnostic power of any IHC test is no greater than the wisdom of the pathologist interpreting it. I have given you some examples of the vagaries of immunohistochemistry, particularly in alveolar rhabdomyosarcoma, but many such vagaries are there. I cannot, deal with all of them. So this is how you go. You do detailed morphologic analysis, then you generate differential, ask the immunohistochemistry markers, then try to solve with this ISC. If not, you look whether there is a specific molecular abnormalities and then order the same for maybe not midline. In case your immuno doesn't come strong positive or diffuse positive, you may have to resort to the FISH test. And of course, wisdom or the common sense is very important. But do not push the tumor in a fixed slot, even if synapto, CD56, CK or MYC2 are positive, as I mentioned, because these are the spurious immunohistochemistry results. So the take-home message will be increase awareness of complexity and diversity of tumors of the sinonasal region is necessary, and one has to aware of it. Always avoid pinpoint diagnosis on pinhead size of tumor tissue or inadequate tissue, because adequate sample is prerequisite for the diagnosis of sinonasal tract tumors. At least you have seen the morphologic spectrum and overlapping morphology. So judicious use of ancillary techniques is key to the diagnosis, and one has to be aware of vagaries of the immunohistochemistry, because your multimodality treatment depends on histologic diagnosis. You cannot forget that sinonasal tumors quite often are diagnosed very lately, okay, and therefore surgery may not be the primary choice. So one may have to give chemotherapy and radiotherapy, wherein your accurate pre-therapy diagnosis on biopsy on the limited material is important. So at least avoid diagnosing on inadequate tissue. See the biopsy is adequate, appropriately use immunohistochemistry. High index of suspicion and experience or wisdom is necessary in view of rare and diverse tumors. And do not hesitate to recommend repeat biopsy when either the tissue is adequate or on adequate tissue also you find there is mismatch between H&E section, immunohistochemistry or clinical presentation. That means clinically it is very high grade aggressive tumor and you see low grade tumor. For example, something like biphenotypic sinonasal carcinoma. Or otherwise, clinically it is a low grade tumor, don't diagnose high grade tumor. And because you must keep in mind that variety and surprises are spice of life, and always